Hello. Let's talk about pulmonary embolisms. And I know this chest x-ray, it's a little difficult. You can see where the embolism is because of the whited out area in that right lung. You can also look at the level of the diaphragm, okay? Look at that cardiac silhouette. Look at the level of the diaphragm. Compare that right lung to the left lung. So pulmonary embolism is a blockage of one or more pulmonary arteries or their branches by a thrombus or other embolic material that dislodges and enters the pulmonary circulation. Emboli can be caused by thrombi, fat, or other foreign materials such as parasites. I had a patient one time that died of a bone emboli after a femur fracture. Epidemiologically, most common cause is a thrombus or a blood clot formed in the pelvis or the legs. Really, the incidence is unknown, and we believe that greater than 50% go undiagnosed. We do estimate about 300 to 600,000 annually, about 100 to 200 deaths per year in the United States. It's a staggering statistic to think that 8 to 10% of people with a PE die within the first hour. So pathogenesis is that a pulmonary embolism is not a disease, but a complication of an underlying issue, a result of a thrombus that's entered the pulmonary circulation, and contributors such as stasis, vascular damage, and hypercoagulability might be present, and often are. Deep vein thrombosis holds the greatest risk for PE, and 10% of emboli will cause cardiac infarct. So, obviously, it enters the heart chamber to then be pumped into the lung chamber or the lungs, and unfortunately, there's also risk of that cardiac infarct. Clinical presentation really is nonspecific and varies greatly, depends where the emboli is, and key or the thrombus is. Key part of the diagnosis is the patient's history. Now, you all know this already. This is true about anything that we're assessing and diagnosing. 85% of what we do and how we diagnose is out of that thorough patient history. But there is a group of patients that are more at risk. So you're looking for this. Recent surgeries, trauma, long bone fracture, like in my example, period of immobility, malignancy, stroke, paralysis, heart failure, smoking, pregnancy, postpartum status, estrogen therapy, and a history of PE or a risk of PE. So knowing those groups and those profiles, clinical classic presentations are shortness of breath, rapid breathing, pleuritic chest pain, and calf or thigh swelling. Tachypnea is the most sensitive sign. Atypical complaints of malaise, weakness, dizziness, syncope, and extremity discomfort might be offered by the patient. So physical exam, again, varies greatly and reflects the nature of the pulmonary embolism. The occult PE may be fatal because it's not routinely suspected or diagnosed, and it might even be benign, though, in contrast, because really healthy lung tissue can filter out small emboli. But any emboli can create cardiopulmonary signs depending on the affected area. So diagnostically, really we're looking at the patient and symptom specific. A pulmonary embolism clinical prediction model can be used to determine the risk of PE and direct testing needs, and look at those examples, the Wells score, Geneva score, and the PERC. Pulse oximetry is a critical part of our diagnostics, ECG. When you start talking about ABGs, troponin levels to rule out cardiac reason, BMPs and D-dimers, chest x-rays, posterior, anterior, lateral, and a VQ scan or spiral CT of the chest, you're really talking about diagnostics that are going to occur at the hospital. Most primary care doesn't have that capacity, but we certainly do on those top few. Management and treatment is really trying to stabilize and ensure adequate oxygenation. Supplemental oxygen should be used as a therapy, and O2 levels should be kept above 92%. You can use bilevel positive airway pressure, ventilation, or intubation if they need support. IV fluids and anticoagulation is still the mainstay for treatment of PE. And I gave you some examples of IV and oral. Referrals, all PEs require immediate evaluation, and traditionally all PEs were treated in the hospital, put on heparin and then converted over to warfarin. But that's not true anymore. There's this group of low-risk patients with adequate support and the ability to participate in care that can be managed as outpatients if they're hemodynamically stable. So patients with chronic PE and infarction should be referred to a pulmonologist for long-term monitoring. Patient family education, they really need to be educated about management of risk factors, avoidance of smoking and immobility, of informing providers prior to surgeries, procedures, or considering pregnancy. Women with a history of PE of childbearing age should not be using oral contraceptive pills for birth control. So patients on anticoagulation must be aware of their bleeding precautions, and there's some specific things: soft bristle toothbrush, wax dental floss, and use of electric razors. No contact sports or other activities that could result in blunt trauma, and they should all be avoided. And anticoagulants need to be taken as prescribed with regular monitoring on an outpatient basis. Now we do have home anticoagulant kits, so it's kind of interesting. Just depends what your patient is on and how much support they need. And I just found a couple of little graphics about pulmonary embolism just because I want you to be able to be so astute in recognizing this as definitely as a differential diagnosis or a suspected diagnosis, so you can get this patient stabilized, maintain adequate ventilation, and get them to the ER. Thank you.